Assalamualaikum. Assalamualaikum and a very good morning. I think it's already 8:05 and we should start our CPC today. First and foremost, I would like to welcome all of you to our CPC today. This is a combined CPC Department of ONG, Department of Radiology, Department of Medicine, and today we are going to demonstrate a case which is a rare complication or rare side effect of medication. But in the end, and it is rare, and in the end, we may not even know the actual cause to the patient's symptom. And without further ado, I would like to call upon Dr. Nur Aisyah Suhaimi, our ONG registrar, to start our CPC today.
Assalamualaikum and good morning. Thank you, Prof. Ixora. Welcome everyone. My name is Dr. Nur Aisyah binti Suhaimi from ONG department. Okay. So today I would like to, I will be presenting this case about a 37 years old lady admitted for medical termination of pregnancy for anencephaly. So this patient, Madam N.A., she is 37 years old, G3 Parawan +1 at 19 weeks of gestation. She has the background history of morbid obesity with BMI of 42 and also GDM. So despite her classification as advanced maternal age, in view she of 37 years old, which means that she carries high risk for chromosomal and structural anomaly. Unfortunately, she missed her nuchal and translucin scan at the first trimester. And then in view of she has family risk factor of DM, age and also obesity, she was benefited from MOGTT, which was done at 13 weeks of gestation. The MOGTT result came back as fasting 9.4 to our postprandial was 15.5, which confirmed diagnosis of GDM. She was started on metformin 500 mg BD in view of deranged blood sugar profile. Subsequently, her BSP was well controlled. Her HbA1c at 16 weeks was 9.1%. In view of advanced maternal age, obesity, and also GDM, she was identified as being at risk of preeclampsia. Hence, we started her on low dose of aspirin since 12 weeks of gestation. She was first seen at our clinic, ONG clinic HCTM. At that time, she was 18 weeks of gestation. Upon assessment, patient was alert, not pale. BP 118/72, which was normal tensive, with pulse rate of 94. No proteinuria or no glycosuria. Per-abdomen soft, thick abdomen, uterus was palpable about 18 week size. She admitted from transabdominal scan, which shows singleton cephalic with fetal heart activity. Unfortunately, we cannot measure the biparietal diameter and also head circumference. And also we can notice a frog eye scene, which highly suspicious of an anencephaly. For the abdominal circumference, correspond to 16 weeks of gestation. Meanwhile, female length was correspond to 18 weeks. And placenta was posterior, not low, with deep vertical pole was 4.79. Okay. So the couple was explained and also counseled regarding finding the diagnosis, the possible outcome, prognosis, determination of pregnancy, and also method of induction of labor. So both of them understood well and agreed for medical termination of pregnancy. So this is the picture of scan, the frog eye sign as I mentioned earlier. And then subsequently, she was admitted 1 week later for medical termination of pregnancy. During admission, patient was well, no sign and symptom of labor. And then termination of pregnancy was conducted according to latest FIGO guideline 2023, whereby we started patient on Tab misoprostol 400 mcg 3 hourly, maximum 5 times per day. So she had the first dose of misoprostol 400 mcg per vagina. It was uneventful. Unfortunately, 2 hours following the second dose of misoprostol, patient had complaint of leaking clear liquor, and then suddenly she had the first episode of generalized tonic-clonic movement, which lasted for a few seconds. The feet aborted spontaneously. However, she remained unconscious. And then we decided to activate red alert. So upon our assessment during that time, bilateral pupil was sluggish. BP was 124/105. She was tachycardia with pulse rate of 113. She was afebrile. SpO2 was 95% on room air. The leukocyte was 6.5 micromole. And then cardiorespiratory system was unremarkable. There was no focal neurological deficit. After we managed to stabilize the patient, then we transferred patient to ICU.
Thank you, Dr. Aisyah. So you've heard the initial part of the presentation. Now, in the interest of the students here in the audience, may I ask you to sana. Ta-da. Huh? Okay. Those who have joined, scan the QR and please list your differentials or just type in your differentials for that particular scenario that Dr. Aisyah has just shared with us. You know how to do it, right? You scan the QR and just type on your phone. It will appear, no names will appear on the board, so do not worry of putting any differentials. It's just for the interest of discussion, yeah? Sorry for the technical delay. So most of you, the biggest font would say that most of you voted for eclampsia followed by anencephaly. That's not the diagnosis for this particular patient, that's for the baby. So drug-induced seizure, reaction, that's not the diagnosis. Sepsis, molar, tuberculoma. Okay, from the eyeballing, oh, somebody got it. This is ni soalan bocor ni. Okay. So you might not have a clue yet. Okay, no problems. Then I call. So the next question would be, those are your differentials. Some get it, some might not get it. So in this particular instances, Dr. Aisyah, what would be your important differentials to entertain? Yeah. Okay.
Okay. Okay. So now we have come to our differential diagnosis. First is seizure for investigation. Second one is throughout amniotic fluid embolism, followed by throughout intracranial or lesion or bleed, and also pulmonary embolism. Okay, now we would like to call upon. Okay.
So those are the differentials that you have to have in mind to follow through with the discussion. Okay, with that particular differentials that Dr. Aisyah has actually said, I need you to just entertain me with the next questions. What investigations, based on those differentials that Dr. Aisyah had actually put up just now, that you might want to send at this juncture? Just pilih. I think you can actually choose one. There's a lot, but you can choose one. Okay. Okay. Hilang. Oh, depan ni. Okay. So most of you chose city brain. 49%. Okay. It's not that all the others are not necessary, but the most important to clinch the diagnosis, yes, in the order of priority would be city brain and all of the others. Okay, I call upon Dr. Chong, my next speaker. Dr. Chong is a radiologist from the radiology department. She will be elaborating on the salient investigation to order and the findings to look out for to clinch the diagnosis for this particular patient. So without further ado,
Hi, morning everyone. I'm Chong from Radiology Department. So we have two CT scans done for this patient. One is a plain and contrasted enhanced CT brain, as well as a CT pulmonary artery, or in short, a CTPA. So as there's no positive finding in these two scans, I will talk more about the basics on how to read the CT imaging. Sorry. Okay, so the first line of radiological investigation for seizure is usually a plain CT brain to look for the causes of seizure, such as intracranial hemorrhage, any acute stroke, space-occupying lesions, or venous thrombosis, which is best seen with a contrasted study. So this is a plain CT brain in axial view. We'll go from top to bottom, but before we go into the anatomical structures, I just want to orientate you on the left and right of the patients on the scan. So imagine you're sitting here and you're looking at the scan. Your right-hand side will be the patient's left, and your left-hand side will be the patient's right side. So it's the opposite direction. So this is why you don't ask the radiologist to turn left or right when they're driving, because they always go the opposite direction following the scan's orientation, okay? Okay, so back to here. So this is the frontal loop. We have the parietal loop. They are separated by a central sulcus, which is not shown in here. We have body of right lateral ventricle here. So next, going down, we have a very important structure, which is the basal ganglia, which is made up of your caudate nucleus as well as the lentiform nucleus. We also have the internal and external capsule in that region. We can see a bit of the frontal horn of the right lateral ventricle and just a bit of the third ventricle. This is the image adapted from the radiologist page. Very good labeling for your CT brain anatomy. So as you can see, again, the basal ganglia, we have the caudate nucleus as well as the lentiform. We have the internal capsule there. Sorry, my pointer is okay. Not working very well, never mind. And then you have your external between the lentiform and also insula. And then you can see the frontal lobe up there and also the occipital lobe at the back. So in every CT scan, we will comment whether there is any midline shift or not. How we do that is that we draw an imaginary line from the anterior to the posterior attachment of the forks, and then we measure the distance from the septum, pellucidum, or the third ventricle to this line. So if there is a distance of more than 0.5 cm, it's called a significant midline shift. For this patient, there is no midline shift. Going down, we can see the temporal loop, the occipital loop, and also at the center here, we have the basal cistern, which is a very important structure as well. It's actually spaces that fill up with CSF surrounding the midbrain. So this picture doesn't belong to the patient, just to show you the basal cisterns are made up of. There is a lot of name for them, interpeduncular, ambient, cura, quadrigeminal cisterns. So next up, we have the comparison between the plain and contrast enhanced CT. So you can see that in the contrast enhanced, all the vessels would light up in the bright color. And in all the CT, we also need to see more than just axial view. So this is a sagittal view with a mid reconstruction, which stands for maximum intensity projections. Means that we stack up all the slides and then we enhance the bright area so that you can see the vessels better. So in this sagittal view, there's a lot of important structures. On the top there, we can see the superior sagittal sinus. You can see the straight sinus, cerebellum. We have pons. So above the pons is your midbrain. Below it is your medulla oblongata. We also have the pituitary gland at the center there. So another thing that we can comment on CT is that if there is any tonsillar herniation, imagine if there is a mass, big mass in the brain, they can cause the pressure and push all the brain material down, so causing a tonsillar herniation, which means that there's inferior descent of the cerebellar tonsil below the light foramen magnum, which is the line dotted in there. So these are just the example of the type of pathology that we can see in patients. So hyperdensity, if it's an intracranial hemorrhage. If it's an acute infarct, it will look hypo. If there is any enhancing tumor or space occupying lesion, it can have a ring enhancement. And for venous thrombosis, we can see filling defect. So you can compare the line there to this area. So you can see this one, the superior sagittal sinus is opacified, but in this one, it doesn't. So this is the example of filling defect in venous thrombosis. So this is how we usually report. So we mention whether if there's any focal brain lesion, any intracranial bleed, any midline shift. We also mentioned about the ventricle south side and basal cistern. So for this patient, the CT brain is actually normal. Going on to the CTPA. So this is the most important view for a CTPA in axial. Usually the indication for CTPA is to look for pulmonary embolism, and in this case, we also want to look for any amniotic fluid embolism. So we can see here, this is the pulmonary trunk and also the right and left main pulmonary artery, which is very well opacified. There's no filling defect within. This is example of how a pulmonary thrombosis will look like. You'll see a big filling defect within the vessels. So if the embolism go across from the right to the left pulmonary artery, we call it a saddle embolism. We can also do a reconstruction with the CTPA. This is in coronal view with mid reconstruction. So you can see that all the vessels are being stacked up. So you can see very obvious all the branches that goes all the way to the side here. So imagine if there is an embolus here, then the rest of the distal branches usually doesn't light up. So for this one, it's all normal. You can see it branch up quite nicely. Next, we also have lung window. So in one CTPA itself, we can reconstruct to quite a few windows to see different structures. So the lung window is usually to see if there's any consolidation, any cavity, any signs of infections of the lung. For this patient, there is none. We can also see the airway. So this is the right and left main bronchus here, which is clear. There is a bit of elevation of the right hemidiaphragm because of the enlarged liver. That's why you see a big lump in here, sorry, at the right side here. So findings for this, sorry. So for this CTPA, there is no filling defect, or the trunk and also the main pulmonary artery as well as their branches are patent. From CTPA, we can also see if there's any cardiomegaly, any enlarged lymph nodes, any lung lesions, pleural effusions. So in conclusion, there's no evidence of pulmonary arterial embolism or any active lung lesion in this patient. Thank you.
So thank you, Dr. Chong. So we ruled out intracranial bleed, right? So the next differential but there's no finding. So we call upon the next differential would be to entertain was to be, because she fitted. Okay, I need to call upon my neuro colleague. Dr. Khoo is here to help us to exclude whether she is actually having epilepsy which was undiagnosed. Okay, I call upon my next speaker, Dr. Khoo, to the stage.
Okay, very good morning to all of you. My name is Dr. Khoo, one of the neurologists from Department of Medicine. So first of all, I'd like to say thank you, big thanks to the Department of ONG for inviting me to talk about this very interesting case. And I'm very much attracted to your answers, actually. I would say that the majority of you have got the answers, I think. Well, this is a discussion, so there's nothing right or wrong. It's about how you formulate according to the rationale, and also the temporal relation of the entire case. So if you're following through, I think one of the things is about whether this patient has a seizure or seizure-like activity, or whether there's any underlying epilepsy, or whether there's any cause that could cause somebody to fit. So that's why I'm called upon. So I will briefly touch upon the approach to seizure and syncope, and I'm given about 10 minutes. I think probably it's not sufficient, but I try to cover as much as I can. And these are the AI figures. These are not the real patient's images. Okay, I think first and foremost, why I'm needed, because we need to order an EEG. Then only the neurologist can interpret the EEG. That's it about that, So I think ordering EEG is easy, You just call us, and neurologists are usually very friendly. We'll come and do, and we interpret and tell you the results then. But we need to always, think about the importance and the indications of doing that, Ordering EEG and ECG is different, Some abnormalities might persist on the EEG. Some probably don't. That's why you need a prolonged, Holter monitoring. EEG, there's a caveat that I need to tell all of you, especially when the EEG is ordered when the patient is well, meaning that the EEG might be essentially normal. And you must understand one thing, a normal EEG does not exclude a seizure or epilepsy. That's also another very important thing. It depends on the timing when you capture it. The ideal situation is, of course, when the patient has a fit and you hook on the EEG electrodes and you get the findings. That's the most ideal situation. However, it's easier said than done. It's not always the case. Therefore, when you interpret EEG, it's important to know what's happening to this patient so that we can correlate. So if you were to tell, I do not want to talk about EEG in a great detail, because that would bore the audience and they will need a lot of expertise and skills in interpreting it. So essentially what we are looking at, we try to put on electrodes and we try to compare the right and the left center, to see, first of all, if there are any abnormalities, meaning that, is there any slowing in particular? So slowing usually indicates an abnormality. It could be, a stroke, it could be an underlying lesion, SOL, that could cause an abnormality. And of course, the most exciting is to look for epileptiform or epileptic discharges. That would suggest that the patient probably has an epilepsy. So what we do is that we compare right and left, look at the background as well, which is very important, and so on and so forth. So this EEG for this patient is actually normal. As you receive a call, given this history, you would probably think that EEG would be normal. However, we'll still do it because just want to be sure that we are not missing any other things. So indications for EEG usually would include first unexplained, loss of consciousness, seizures, and also most importantly in the ICU setting, when someone is not waking up, the majority of the workup seems to be unremarkable. That would be something we call a non-convulsive state or non-convulsive status epilepticus. So that's also a very important indication to do an EEG. So her EEG is normal. So what does it tell you? Okay, so at least, from the story and the EEG, it doesn't sound like an epilepsy, right? Because the patient, if the story is true, doesn't show that this patient has a history of epilepsy. So it's just that particular event. So I would like to highlight something about when we see somebody with a history of transient loss of consciousness. These are the two things that we want to pay attention to. Yeah, it's either a syncope or a seizure. So syncope basically is just, by and large caused by a transient global hypoperfusion or hypoxia, meaning that you don't have enough supply to the brain and you just faint and collapse. Whereas seizures, you get this ictal event, that would be probably involve more than just global hypoperfusion. It's probably, involving the epileptic network, brain network that causes, the disequilibrium between the, inhibitory and the excitatory nature of the brain, causing you to have a clinical seizure. I want to highlight this, in order to differentiate between these two conditions, it's not about the imaging and the other tests, to tell. The most important thing is actually your history taking and your witness account. These are the two most important parameters when it comes to diagnosis. Yeah? Because the other tests are actually used to just confirm or to, complement your hypothesis. So you must have a hypothesis for that. Okay, it's a bit busy slide, but I try to just tell you what will point towards a seizure and what will point towards a syncope more likely. So this is the story that we need to try to get. That's why when a neurologist comes, we will try to ask a lot of story, a lot of history, as much as we can, because this is the way how we can formulate our hypothesis, rather than, patient comes in with a seizure, please do a scan. Without going through the history, it could be harmful at times because we do not go to the bottom of the diagnosis. We just hope that something positive comes out. Unfortunately, and in many cases, something so-called positive turns out might not be related to the diagnosis at all. Therefore, history taking, going through the witness account is the most important thing that I want to highlight again. So if someone tells you that, before I faint, if he or she can tell, I feel that I'm going to pass out, I feel like the whole world is like spinning, I sweat a lot, and the patient looks pale, for example, someone, sitting or standing next to the patient, that would probably point towards a syncope. However, if I have an aura, for example, I see something funny, that is not existent, but I see it coming, I see, some animals becoming bigger, smaller. I see a lot of Prof. Nafizas, or Prof. Anizahs, that's very strange. This has never happened before. And after that, you faint and you can't remember, that would probably point towards a seizure, aura. And of course, sometimes people will say about cyanosis, yes, versus your face turns, pale. If your face turns pale, it's more of a syncope versus your face turns cyanotic. That would point towards a seizure. Tongue biting is also very important, especially the lateral side of the tongue. Yeah, if after injury, you see a bite mark on the lateral side of the tongue, that's most likely a seizure. Whereas if you have a bite mark at the tip of the tongue, it is probably a psychogenic seizure. Yeah, actually we can do it, but it's quite difficult to bite the lateral side. You can do it at home. Yeah, don't do it now. Okay, and of course the post-ictal part. Yeah, syncope usually very fast. The moment he feels or she feels unwell, pengsan, and you wake up, or probably patient will just wake up within minutes, 1 to 2 minutes. Whereas the seizure will be followed by quite a long post-ictal drowsiness. So usually patient will snore and slowly, wake up. Incontinence, probably not so useful. It can exist in both conditions, yeah? Okay, so ladies and gentlemen, that's another thing that I want to tell you, because that's probably not a really a very commonly used terminology, among the non-neurologists. So convulsive syncope. So it's actually a syncope. It's a fainting episode. However, it behaves like a seizure. So it's very challenging, yeah? That's how a lot of times we would be baffled by the history because someone would just tell, okay, someone comes in with a seizure. So even if somebody tells you, or the triage, tells you that this is a case of a seizure, please again go through the history. As you can see from here, it's actually, I think, published in somewhere in 1982. I think many of us were not even born at the time. They found out that when somebody faints, you can have a seizure-like movements up to 12%, meaning that up to every 10 patients who present with a syncope, 10 of them, one every 10, yeah. So 1.2 of them will actually have a seizure-like activity. So this seizure, it can be a GTC, it can be, just myoclonic jerks. There are also documented videos of focal automatism. So they will turn around, head turning, climbing, combing hair, and so on. So due to time interest, I can't play the video. Yeah, you can go to this YouTube. You can take a picture of this. You can type convulsive syncope. This video was taken, I think, by this author, Lambert, in 1994. What he did was that very interesting. He just asked around 50 or 60 medical students who are literally healthy. Probably we can, do this study again. So they asked all these healthy medical students, ask them to squat, hyperventilate, do some Valsalva maneuver just to induce a syncope. And they took a video. And interestingly, yes, so I can't play it, during the CPC. You can go and have a look. Yeah, some actually had, GTC, myoclonus, and even head turning. And one of them is very interesting, was like combing hair. Like a focal automatism. Therefore, none of them actually have a true seizure. These are all the convulsive syncopal attacks. So I hope you understand by now that, so the take-home message is that if somebody tells you that someone comes with seizure, again, go through the history, preferably with a witness account. Okay, again, acute symptomatic seizure. So these are the terminologies to guide you, what this process is here. So principally, acute symptomatic seizure, it's a seizure, yeah, occurs very closely related or closely related with a close temporal relationship with a brain insult. So how do you define? So if you have a traumatic brain injury, you have a stroke, yeah, within a week, you develop a seizure, then we say this acute symptomatic seizure. Because you can understand, right? After an insult, whatever it is, either it's bleeding from the brain, from a tumor, it has a lot of edema, it has a lot of, ongoing pathological process that will cause the abnormal neuronal activities in the brain, resulting in acute seizure within a week of an organic insult. And 24 hours, yeah, within any metabolic derangements, for example, hypoglycemia, hyponatremia, hypokalemia, and so on and so forth. Therefore, screening, like what the ONG department has done, taking the sugar. So when somebody has a seizure, taking sugar, it's the first thing that you need to do to be sure that there's not hypoglycemia in particular, yeah, as well as the other parameters like potassium, sodium, and so on, yeah, urea, creatinine. And of course, last but not least, principally drugs, anything that could cause you to have a convulsive episode, it needs to be screened through. Is that all right? To acute symptomatic seizure. Why we need to know? Because this is just to explain why a person has a seizure. And most likely, this patient may not need anti-seizure medication in the future. Because, for example, if you have a seizure because of hypoglycemia, what you need to do is just address hypoglycemia, right? You don't need to put the patient with, sodium valproate, carbamazepine, right? Because this is not an epilepsy. Yeah. So again, this is an important slide, I think, just to tell you, if you have an acute symptomatic seizure, it does not mean that you have epilepsy. So seizure is a complaint. You come in with a seizure, then we try to work out. Either this is a convulsive syncope, either this acute symptomatic seizure, or actually you have epilepsy. So epilepsy is a disease. So seizure is a complaint, epilepsy is a disease in which you have a predisposition or you have a tendency to develop seizures. And usually the causative of which is unprovoked. For example, I'm delivering a lecture. Yeah, I ate my breakfast. I wasn't stressed. Okay, then suddenly I have a seizure. No reasons. Then this is what we call the unprovoked seizure. So 2 episodes of which occurring more than 24 hours apart, then you have to think about epilepsy. Why is it important? Because if somebody has an epilepsy, most likely you need a medication. You need to be treated. Okay? So I hope I make this clear. And last but not least, I just had to look, whether so if you are following me, you know that okay, the CT scan was normal, yeah, EEG was normal. Given the temporal relationship, we have to think about whether could be something else, yeah, because we want to solve the mystery. That's the purpose of us here. So you can see that there are a few case reports. Even in Malaysia, I think it's reported in Sabah, I think so, yeah, if I'm not mistaken, has reported a case. Principally, we always have to go through, so assuming that the CT was normal, it was really normal, and the biochemicals are normal, EEG is normal, yeah, so what else? We always have to go through the other new things that we have introduced, whether it could be related. So that's how, as a clinician, that's how we should formulate the thinking, and that's the reason why we are here. So with that, I will pass back the stage to Prof. Anizah.
Thank you, Dr. Khoo, for the very interesting talk, and we learn a lot. Dr. Chong too. I hope the students are benefiting from the run-through working out of seizures and the CT brain and CTPA. So, Dr. Khoo has actually let the cat out of the bag. So I'm just continuing, okay? Okay, I'll be the last speaker and I'm going to sum up the session and hopefully give you some answers. So I titled my presentation as an unexpected turn of events during TOP or termination of pregnancy, lessons learned. Okay, so we are back to square one. So we had some differentials, right? Remember, we have excluded intracranial bleed. The most important thing to exclude in the terms of, in the order of significance are stroke and ICB. That's excluded. Thank you to Dr. Chong and the run through of the radiological images. Okay. Then epilepsy is another thing to work out. That also has been excluded. So also pulmonary embolism or even amniotic fluid embolism in this particular case. So now that everything is excluded, what does our patient have actually? So on the other side, all other investigations, we did dextrostick, electrolytes, ECG. There were some changes that we were thinking of pulmonary embolism, but that has been excluded too. And other imaging such as chest X-ray were normal, even her echocardiogram were normal. So we are dumbfounded until somebody said that, okay, while telling you that, I need to update what happened to the patient. She was monitored in ICU and was stable throughout the night. The following day, she was stable, fits free, then she was transferred to our obstetric HDU, high dependence unit, and she spontaneously miscarried, aborted, thankfully. So it was uneventful at that particular moment. And she recovered well. She was able to be discharged a few days later. She was given the bereavement counseling and followed up. And they were given advice for contraception. And she was advised for early checkup. So we've seen her once in the clinic thereafter. She's fit, free, and was very well. But still, we did not know what happened and what was the diagnosis in this particular lady. I think Dr. Khoo's team alerted us, the obstetrician and gynecologist, could it be misoprostol induced? So as an obstetrician, we've been using misoprostol a lot. It's a time-tested drug. I don't have any shares in the company, but it's a medication that we've been used for a long time. So is that a diagnosis even to be entertained? We've been using this medication for ages and there's no problems with it. But we can easily refute that and say, neurology don't know anything. No, but we don't do that. We take into consideration everything that can be explaining the presentation of our patients. So a bit of introduction in the interest of the audience. Misoprostol is actually a synthetic PGE1 analog, which is on market label for use of treating or prophylaxis treatment for peptic ulcer induced by NSAIDs. However, obstetricians use it a bit more. We are using it a lot more for off-label indications, which is for a variety of indication for medical management of miscarriages, termination of pregnancies, priming of the cervix prior to surgical procedures, and as well as for treatment or prophylaxis of postpartum hemorrhage. It can be administered via 5 routes, which is oral, vaginal, sublingual, buccal, and rectal routes. The wanted effect of misoprostol is the softening and of the cervix and uterine contraction. However, it carries with it unwanted side effects such as nausea, vomiting, diarrhea. You can get fever, hyperpyrexia. The uncommon side effects reported are delirium and confusion. And the most feared side effect would be uterine rupture. Those are available in the drug insert itself. Its advantages and why is it popular? Because it's cheap, it's widely available, and it's easy to be stored without needing any special refrigeration. It carries a 1% risk of teratogenicity, so that to be cautious to be used in patients who have that risk. The toxic dose is not easy to, there's no papers on a particular toxic dose in the humans has not been established, but it is well tolerated up to a cumulative dose of 1,600 microgram. So this table is a bit busy, but it's practically summarizing the properties of the different routes of the misoprostol. To sum it up, it depends so much on what is your indication, the gestation of the patient, or the need for the misoprostol in treatment. And it's very popular vaginally because it's greater drug exposure. So it causes the most response to the cervix and uterus via vaginal route. The sublingual route has the fastest onset of action. So it's fairly popular to be used in certain countries for PPH management. However, it carries with it more GI symptoms. So it depends on the doctors and the indication to choose which route is suitable. So what is our practice in Malaysia? This is a guideline recommendation of use of misoprostol in Malaysia in ONG situation. So this is a figure insert in 2012. This is the different regime of misoprostol for different indication per trimester. So this is this figure regime has been updated recently to 2023. This is what we use for our particular patient. She's in the second trimester, she's 19 weeks, right? So we use the 400 milligrams every 3 hourly. Okay, she was planned for actually 5 doses, but she only managed to get the second dose and she fitted. So we stopped the termination of pregnancy. So those are the slides on misoprostol. Does it really cause an adverse reaction so that patient fits? So what are the evidence? So we were searching high and lows for evidences, and we found the same paper that Dr. Khoo mentioned. This is a local published paper last year. I've actually summarized the paper. It practically tells about 2 cases, one involving a Gravida 2 Parawan, 32 years old, self-medicated to terminate pregnancy, which was at 16 weeks. She was brought in by the husband to A&E with complaints. I can't see my slides actually. With complaints of abnormal behavior, and then she was brought into the emergency department, and then she practically fitted there. 1 minute, I need to move my slides. Basically, when the patient fitted, she was stabilized and resuscitated. Okay, yeah, better. So she was given antipyretic because there was fever documented. Then she was woke up similarly to our patient, and frustratingly, everything turns out normal. There's only one fit episode, and that was the final diagnosis for that particular patient was misoprostol-induced convulsions. Okay. On the same paper, it tells of another case for a 15-year-old primary gravida. She's in her second trimester. Again, I forgot to mention the thing to highlight in the first slide. The first case was that the patient used the oral doses and 3 oral doses and 2 vaginal doses. The cumulative dose in the first case was 1,400, still below 1,006, right? The second case was a self-medicated patient for induced abortion at second trimester. She used 3 doses of oral misoprostol and 2 vaginal doses. Her accumulated dose was about 1,000. She was brought with GTC to A&E. Similar to the first one, however, it aborted after 3 minutes and she was given 1 dose of diazepam. And then she remains fit-free and was stable. Again, all investigations were normal and she was stable enough to be discharged a few days later. And again, the diagnosis was misoprostol-induced convulsions. Then that was local papers. We found another paper which was published for publishing about a case in India. Oh, sorry. Is it moving now? Is my slides moving? Tapi tak gerak di case tu. Okay, now it's moving. Okay, this is another paper telling about a case in India. This is practically a primary gravida. It happens in Meghalaya, India. This is a paper published earlier. That was 2024. This is 2017. This is for a different indication. This practically was a lady came in labor. She went and delivered uneventfully. Had the third stage actively managed, and she was given misoprostol as a prophylactic against PPH. Whether it was the protocol at that particular center, I'm not sure. It wasn't elaborated. However, after I think half an hour after that, she developed fits. And then I need to move around because I can't read. And then she was loaded with phenytoin, and true enough, all the investigations were normal. However, she was discharged with a phenytoin dose on night. The diagnosis in that particular case was again misoprostol-induced seizure. And this is another paper, again in India, but it's in New Delhi, published in 2009. This is a bit different in the terms that the patient was gravida 2 para 0+1. She had a known case of tuberculoma of the brain. So she had been fit-free for 2 years. So when she presented, the presentation is nearly similar to our case. She was diagnosed with an abnormal fetus, whereby the fetus had large lumbosacral and meningomyelocele, and requiring termination of pregnancy. The patient was at 16 weeks. The route of misoprostol termination of pregnancy was carried out vaginally. Similar dose to our patient, she had 800 total cumulative dose, and she was actually planned for only 3. And then she was admitted, and after the second dose, similar to our case, she developed episodes of generalized tonic-clonic seizures, which was aborted, given diazepam, and then she was stable enough. And again, similarly, all investigations were normal. So the diagnosis was again misoprostol-induced convulsion. So having gone through all these evidences, although it's case reports, because those are the only available evidences so far, we are comparing to our own case. So practically, this is not published yet. So it's fairly similar to the last case I've discussed, but are we to entertain the similar diagnosis? So what can we learn from those discussion overall, that we know now that despite its widespread use, misoprostol carries a potential adverse effect that can be manifesting in seizures. However, we are not able to postulate who would end up with seizures because the etiology of the seizure itself is poorly understood up till now. So it should be used with caution by direction from the healthcare practitioner, and should not be used self-initiated like the first two cases, which was self-induced miscarriages. So you should be guided by recommendation guidelines and dose and under doctor's advice. So although this particular presentation of seizure is fairly rare, it shouldn't be acknowledged and should not be brushed aside. So final diagnosis, likely misoprostol-induced seizures. However, like my opening sentence by Prof. Ixora said, will we ever know for sure for this particular patient? We are not sure. But this is an entity to be entertained. So critical take-home messages for all in the audience and the medical students as well. We never stop learning, and we learn from various sources. In this particular instance, when Dr. Khoo alerted us of his team alerted us of there might be possibility of misoprostol induced, we were like, what? So, but then we go and search about evidence and we learn something new. So, evidence-based medicine complements our practices and enhance our knowledge and enrich our daily practice. We should remain open-minded at all times and be able to discuss and ask around and ask opinion and do our own search. With that, we're bumping into walls when we're managing patients. And for the benefit of medical students, the process of working out a patient towards a diagnosis is as important, if not more, than clinching the diagnosis itself. Okay? So, do we change our practice now? Do we not use misoprostol? Can I have a hands in the audience among the obstetrician who would not use misoprostol after this presentation? Okay, thankfully. Okay, so personally, I think it is still fairly safe to use, but we need to be cautious, abide by the guidelines, and be aware of this potential adverse but rare side effects. And if we are faced with a similar case, it's important to exclude the commoner causes of seizures on syncope and run through thoroughly working out the patients. And again, to emphasize the multidisciplinary team approach. So with this, I would like to thank the audience for your presence today, and I hope you brought things back and learned something from everything. Thank you to all my presenters. For the benefit of medical students, I need to put up an important slide so that you go back with something. Yes. Yeah.
Thank you very much. A very interesting case and very beneficial for the medical students, especially year 5 who are going for ikhtisas kan, August? Okay. So because I saw the majority answers eclampsia, can you tell us why is this case is not likely to be due to eclampsia?
Okay, thank you for the question. Yeah, I forgot to run through the thing. Okay, it's correct to entertain eclampsia because this is a pregnant lady. However, if we were to, I can't put up the slide because of the technique. She was 19 weeks and her booking blood pressure was normal. The diagnosis of eclampsia is made after 20 weeks of gestation. So that's the only thing. But yes, you're correct to think of eclampsia first. So I'm fairly proud to have eclampsia, the biggest one there, but we are working it out. Okay. Does that answer your question?
Yes, because I think it's important for the medical students. And second thing, I saw in the blood investigations results, the platelet was 97 and the APTT was slightly prolonged.
The blood investigation result. I think ours was normal, right, Aisyah? It was normal, but we had a few investigations done over the time.
Yeah, because it's very important if let's say in this kind of patients with thrombocytopenia and prolonged APTT, you should think of antiphospholipid syndrome, which
Yes,
can have
correct.
some
But in this particular patient, her blood investigation were all normal.
Okay.
Okay. Why I needed to put up this particular slide? Can you the following are common differential diagnosis to consider in a patient with seizure and leaking like what? Except. Yes. Okay. Okay. That's it. I don't want you to consider misoprostol first, but do not totally forget this presentation. But you need to work her up for the more commoner differentials. Thank God. I don't want you to put after this kan nanti medical call I diagnosis misoprostol induced. Okay. So thank you everyone for your time and assalamualaikum warahmatullahi wabarakatuh.